Good afternoon, everyone, and welcome. Thank you for joining us today. For those of you who have been on previous webinars, today's session forms part of our orthopedic surgery webinar series, and we focus on how expert evidence is applied in complex medico-legal claims. Today, we will be exploring how recovery is evaluated following hand injuries, how ongoing symptoms and limitations are measured in practice, and quite interesting, why differences in expert opinion can have a significant impact on future loss claims and settlement strategy. Now, before I introduce you to our speaker today, just to let you know, for those who, again, perhaps haven't come across us, INNEG is a specialist organisation and a specialist agency who help with the sourcing and management of expert witnesses. If you require experts across all areas of medicine and surgery, we have availability on our panel nationally across the UK. You can find out the different numbers of different experts we have on our website. And if we're talking about orthopaedic experts, we support and we have on our panel experts from all different areas of the body, whether it's hands and wrist or spine, upper limb, lower limb, and the rest. Now, without further ado, I'm very glad to welcome back Mr. Rupert Wharton, who actually, for those of you with long memory, spoke to us and presented 2 years ago almost in June, July 2024. And we're delighted to have him back. Before I pass you over to him, I just want to highlight that we will be doing a chat function, which will be in above. So any questions you have, pop them in the Q&A or the chat function above, and we will try and get through as many as we can at the end of the presentation. Additionally, the recording and the slides will be made available to you in the next few days, so don't worry, they will be emailed across by our marketing team. Now, Mr. Rupert Wharton, he's a consultant trauma and orthopaedic surgeon specialising in hand and wrist, and practices at Kingston Hospital in London, as well as King Edward and the New Victoria Hospital. He's quite specialist in what he does, and I don't want to spoil his thunder because I'm sure he will touch upon the different types of wrist and hand surgery that he does. So without further ado, Rupert, I'm delighted to welcome you today. Please take the stage, and we look forward to hearing your presentation. Thank you very much.
That's brilliant. Thanks, Leo. So, yes, I'm a consultant hand and wrist surgeon based in central and southwest London, as Leo mentioned, and my NHS is in southwest London, where I am now, and I run a private practice through the New Victoria, King Edward VII and Princess Grace hospitals across that jurisdiction as well. I've been writing personal injury reports since 2023. And my initial training was through Bond Solon, and I remain accredited through their annual CPD program as well. So when thinking about what our role as expert witnesses in hand and wrist surgery might be, I suppose anytime I'm faced with a problem, my intention is to think about what might the court reasonably be expected to know. What might they expect to be a reasonable outcome from a particular injury pattern? Where is that knowledge gap? And so that would be my role to try and fill that. And how can that be explained without jargon so that somebody can pick up and read a report in plain English without the need to reference an index continually? Nobody's professional journey is complete without mentorship, and I'm indebted to the two gentlemen on the screen at the moment. So on the left, Mr. Mike Hayton, who's a consultant hand and wrist surgeon in Wrightington Hospital in the northwest of England, and on the right, Mr. Dan Armstrong, a consultant hand and wrist surgeon in Derby in the East Midlands, both of whom have supported me along a clinical and medical legal journeys. So what makes the hand special? Well, some of the following images are taken from a beautiful book by photographer Tim Booth, who has outlined his views on how the hand might interact from the point of view of professional art. But of course, everybody's hands exist as an reach of their own creativity, and that might then overlap with their professional practice. And in fact, their professional practice may involve skilled labor, and if you lose hand function, then the impact on families as well as the individual can be quite significant. Hands always tell us a story, and it's the role of the hand and wrist surgeon as an expert witness to try and unpick some of the subtler signs that hands might tell you, and to identify whether they corroborate with the story offered. So, for example, those of you who go to the gym regularly or who row or who cycle, when you look at the front surface of your hand, may identify callosities that form across the front of the knuckle pads to give you, which are a response essentially to shear or to grip forces anytime you're lifting weight. And those are fairly reliable. So if somebody has suggested that they are struggling with work or hobbies, I would expect not to see any callosities across the front of the hand. And conversely, if there are significant callosities, then that would suggest that the hand is being used in some kind of grip or shear activity without significant trouble. And so that's a subtle sign that helps me to understand the corroboration between what the hand is telling me and what the story is being told by the claimant sitting in front of me. And sometimes the opposite is true. So hands that are suffering from disuse may corroborate a similar story. So if somebody has significant stiffness of a joint, then they over time will lose the flexion creases that we all have across the front of our joints that form the folding of the skin as we move the joints. And if you see somebody with significant joint stiffness over years and years and years, those creases will disappear. And so that's a good example of how somebody's story may map with objective evidence at hand and wrist examination. Of course, it's 2026 now, and we're all being encouraged to engage more with a work-life balance. And you can appreciate that if you sustain an injury to your hand or wrist, that means that you lose your hobbies, then the impact on that individual may be fairly considerable. You know, our opportunity to have time away from work and to de-stress and to disengage with the stresses of everyday life are taken away. And the hand is an important aesthetic instrument as well, and that has a relevance on expert witness practice from a hand and wrist point of view. As humans, when we interact with individuals, we look at people's faces and we look at the backs of hands. So if you have a scar or a deformity that's visible from the back of your hand, that will be very aesthetically apparent, and it may be in some circles socially stigmatizing. And so the impact on that individual will be quite considerable. The reverse is not necessarily true. So if you have a scar or a deformity across the front surface of your hand, across the palmar surface, that's much less noticeable in everyday life. Similarly, if you lose a finger in entirety, it's often not that noticeable following particular types of surgery. Whereas if you have a finger that is noticeably shorter than the others, that is paradoxically more noticeable. So all these little nuances of clinical practice in hand surgery feed in then to how expert evidence is delivered in the context of a report. There are some other little nuances about clinical practice of hand surgery that are relevant to expert witness reporting. And there are two on the screen at the moment. So these are x-rays of somebody with rheumatoid arthritis. And this is a really severe case. And anybody who's had a bit of an opportunity to look at x-rays in the past might recognize that there are too many bones overlapping here. So this person's rheumatoid arthritis, which is an inflammatory condition where the body is attacking its own joint cartilage and supporting structures around the joints. In this individual, there have been dislocations which have happened over time at the wrist joint, the distal radial on the joint on the side of the wrist, the knuckles, and then further down in the small joints of the hand. So this is a very significant case and really quite advanced case on X-ray, and it might stand to reason that you would think that that person's function would be awful. But actually, often in clinical practice, the reverse is true. Often these people function very, very well. They can do up buttons, they can use a knife and fork, they can make a cup of tea, they can operate a vehicle. So in the hand and wrist particularly, function correlates very poorly with x-rays. The second factor is that surgery in the hand and wrist may not necessarily improve the natural history of a condition. So if you have a significant injury, particularly to some of the smaller joints of the hand, they may be broken into multiple small pieces, and a surgeon meeting a patient in the clinic might not feel that any of their surgical techniques could actually improve on the function of that hand above and beyond a plaster cast or a splint, gentle exercises, and then seeing how the patient does in the future. So if you're instructing hand and wrist experts and you're meeting with claimants who have had an injury, you shouldn't necessarily think that just because somebody didn't have an operation, their injury wasn't severe. It may simply be that the surgeon meeting them didn't feel that they could actually make that hand any better, and these two things are distinct. The converse is also sometimes true. So occasionally I come across people who have had several operations to the same finger following an injury. And it's important from my point of view to bear in mind that that doesn't necessarily direct the severity of that injury. It might simply be that the initial surgery didn't go quite according to plan and that subsequent steps had to be taken in order to rectify that. So all of these things are kept separate in my head when I'm meeting the claimant and then subsequently writing the report. So how is the assessment done? Well, I suppose there are subjective and objective measures. Subjective being what the claimant tells us when they come for the interview, and objective being what we find on examination. In terms of subjective measures, I find these patient-reported outcome measures really valuable. So these are photographs taken from the DASH score, disabilities of the arm, shoulder and hand. And this is a validated scoring system that we use in clinical practice, that we use all of the time in clinical research, and is very, very helpful in medical legal practice as well, because this questionnaire is designed to screen out specific activities of daily living, and then the claimant, or in clinical practice, the patient, will give you a score which will tell you how they're suffering and gives you a fairly good subjective measure of how their hand is functioning at the time of our meeting. But then, of course, there are the objective measures as well. And so that can't be influenced by the claimant. And those include tenderness on examination, joint stiffness, joint stability, range of movement, which will be measured accurately with a goniometer, grip strength, and then the neurovascular status. And all of those will feed into the report. So there are a number of slightly gruesome photographs, and I have assumed, I hope correctly, that those of you instructing personal injury cases would have seen similar clinical photographs, but this is just a warning that there are a few populated throughout the presentation. And these cases are actually drawn from image banks where patients are given permission for images to be used. So when we come to talk about real life cases in the future, the images don't tally, and I've done that deliberately to not prejudice the outcome of any ongoing case. So finger injuries, well, these are very common, especially in manual workers. And there are several considerations that, as a hand and wrist expert, the court will want an opinion on, and those include cosmesis. There's obviously going to be a huge cosmetic element when we've already discussed the fact that when we communicate as humans, we're using the back of our hands a lot for aesthetics. So any shortening of the digit, loss of the nail plate, which is the name that we give to the nail itself, or any of the supporting structures of that nail, will be very noticeable, and they can be very stigmatizing to people, and there can be quite significant psychological trauma that comes along with that. The finger is designed to have a set length so that it can dialogue with the thumb. And so if either the finger or the thumb is shortened, there will be an impact on function. It's not always as great as you might assume. And in actual fact, people can tolerate mixed amputations at the distal phalangeal level quite well without necessarily having significant functional issues, but each person's experience of that will be different. And then there can be future issues. So there is a particular deformity that people can get following a tip amputation, because the nail will continue to grow. The nail actually grows from just downstream of the joint crease that you see across the back of your finger. So what you see will have taken several weeks already to grow to that point. And if you lose the supporting structure, so the sort of pink fleshy bit underneath your nail, which is the nail bed, if that supporting structure is lost, then the nail will grow downwards, it will curve downwards afterwards. And particular operations may need to be done as a consequence of that in the future. And it can be many years before somebody comes to undergoing that secondary surgery. If we move further up the finger, to the joint just downstream of the knuckle, so the knuckle being the metacarpophalangeal joint, the next joint down is the proximal interphalangeal joint, and these joints react really poorly to injury. So you may be presented with somebody who's had imaging that looks like it shows a relatively innocuous fracture, but these joints always become very stiff, and the stiffness actually can be really extreme and really functionally limiting. So just because the X-ray looks like there was a little slither of a fracture doesn't necessarily mean that the person's function will be good. So we tend to describe these as a small fracture leading to a big injury. And again, just as reinforcement, we have to bear in mind that the fact that a surgeon didn't think that they could improve on the natural history of that injury doesn't mean that the injury wasn't significant. We move on to the hand. These are broad brush strokes before we think about specific cases. Hand injuries, by contrast, are generally very well tolerated. So you might sustain an isolated injury to a metacarpal, and in many cases those will be managed non-operatively. And in this case, it's not because the surgeon didn't think they could make it better, it's because they generally do very well in the future, even if there is some residual deformity. Surgery is often not required for these conditions, and there's a significantly less chance of joint stiffness around them. And that is true whether they've had an operation or not. If they have had an operation, though, the plates or screws or wires that have been used to fix the bones are commonly irritant to the soft tissues that run, the tendons that run across the back of the hand. And so a secondary removal of metalwork is common, and then that will be listed as a potential future recommendation in the report. And then if we move even more proximally to the wrist, no two wrist injuries are really the same. And you may be presented with a claimant who has had a relatively innocuous injury and a minimally displaced distal radius fracture, who by 6 months is almost symptom-free and back to doing all of the activities and working life that they had prior to their injury. Similarly, you may be presented with somebody who's had a distal radius fracture with a ligament injury in the wrist, and those can be really very severe, or somebody who's had an injury that is where it's difficult to predict the natural history. And the example on the slide here is a fracture that you can see through the scaphoid bone with some reabsorption of bone around the outside. And those of you who have a passing interest in wrist injuries may be aware that the scaphoid bone is a bone with a funny blood supply. The blood supply runs back on itself, so it runs downstream and then down through the scaphoid. And that means that whether or not it heals can be unpredictable. And so surgery is often carried out to try and improve the chances of healing. But even despite that, sometimes the writing is on the wall from the injury and the bone doesn't heal. In general terms, for wrist injuries, loss of grip strength is pretty common. And the pain that they get from an isolated injury, whether or not it requires surgery, often persists for 12 to 24 months. So if you're sending somebody with a wrist injury to a hand and wrist expert, and they are, certainly if they're less than 12 months following their injury, it may simply be too soon to know whether the current symptoms are going to get better on their own. And so sometimes a later appointment would be preferred in the context of those injuries. Lastly, it is often the case that the initial imaging may be normal, especially in the case of scaphoid fracture. So if somebody presented to their local emergency department and underwent x-rays and was told that everything was normal, it's quite reasonable for that individual then to have carried on their daily life. And when they come to see you for help regarding their claim, you may be the first person that they've presented to subsequent to the injury. And if they've not had any follow-up imaging, then it may be simply that it was too soon for an injury to show up on the initial x-rays, or that the appropriate investigations weren't taken because they never saw a specialist. So those factors will be important then when they come to see us for a report, and we frequently would recommend follow-up x-rays plus or minus an MRI scan at that point. Sometimes the injury doesn't involve the bone, and sometimes it involves the bone but can't help but involve the soft tissue envelope around the bone as well. And so we commonly in both clinical practice and in medical legal work come into context of tendon injuries. In the top left, it's clear that there's been an open injury here and there must have been a fracture in order for that deformity to have taken place, but they can be more subtle. And in the image in the top right, here's a presentation of somebody who has lost the function of the tendon that is designed to bend down the tip of the ring finger. And that functional loss actually is really quite significant, and it's also very difficult to rectify surgically. They often present late because there hasn't been a cut in the skin, so they don't see the need to attend the emergency department, and they may be looking at 2 operations with quite a significant risk of complication there. Similarly, in the image in the bottom right, sometimes they might have gone to the emergency department and still the diagnosis may have been missed. So here's somebody who has a normal resting cascade of the index and middle fingers. So the cascade is the terminology used to refer to how your hand normally sits. You can imagine if all the muscles were relaxed, the fingers still aren't held in true extension, and that's because the flexors are generally more powerful than the extensors. So in this injury pattern, somebody's lacerations have been sewn up, but it's clear that there's been an injury to the flexor tendon as a result of that laceration. And sometimes the tendons are okay, but the nerve has been injured, and there are 3 main nerves that supply the hand and wrist, and any combination of those can be injured, but some injuries occur in locations that we in the hand and wrist community would consider classic for a particular injury pattern to a nerve. So in the top right here, if you saw that kind of injury in clinical practice, you would be thinking that they have a high chance of having a median nerve injury. And so the median nerve is the one that supplies sensation to the thumb, index, middle, and half of the ring finger, as well as powering the muscles of the thumb, the ones that move the thumb out of plane of the fingers to allow the thumb to dialogue with the fingers and enact a pinch. And so loss of that function is disastrous for hand function. And in the image in the bottom right, that's a kind of classic position for an ulnar nerve injury. So the ulnar nerve runs down on the little finger side and will supply little finger and half of the ring finger, as well as doing small muscles of the hand, so the ones that allow you to move the fingers in and out. These injuries can be either involving a partial injury to the nerve, so that would be either partially sensory or partially motor, or they can be combined. Sometimes patients are relatively symptom-free, and it might just be that small branches of these nerves have been cut with lacerations or damage with blunt trauma. But the suffering can be extreme, and it's often the case that if a nerve has been cut, it tries to find the other end of the nerve by way of healing process. And if it can't find the other end, or if it doesn't connect properly, it will form this little bulb of nerve tissue, which then is very, very sensitive if it's ever knocked. And often these are manual laborers and their hands are being knocked all the time, and they get this horrific electric shock type stimulation, which we call a Tinel response. And that can be very limiting in terms of what activities they're able to do afterwards. So let's think about these injuries in the context of some cases. So this first case is a patient in their 40s, or a claimant in their 40s, who is left-handed, works in healthcare, but is self-employed, and suffered a tip amputation of their thumb in a crush injury. The amputate, which is the bit of tissue that was lost, was felt not to be replantable in the local hospital, and that person underwent a terminalization operation. So terminalization is a way of tidying up the remaining tissues, often involving shortening of the bone, shortening of the nail bed, with an intention of just getting the skin to close to reduce the risk of infection. But they had subsequently been to see somebody who'd had a discussion about possible later reconstruction. And at the time that they came to see me, a year or so after the accident, they had significant functional limitations. So this person was unable to write, unable to wash their hair, unable to open a tight jar. So my report there needs to focus on the procedure that they've undergone, which is terminalization, and that procedure has specific risks. So you can imagine if your finger is shortened at any level, the two nerves that go on either side to supply sensation have to be cut. And in fact, they're usually damaged by the injury. And management of them is challenging during neuroma operating. And it's challenging enough that they then have a 33% or 1/3 chance of ongoing neuropathic pain, such that every time they touch that area of the bulb of nerve tissue, they get this really noxious electric shock response, which stops them from doing what they're doing at the time, but also makes them want to avoid that activity in the future. And so essentially, for a relatively innocuous sounding injury, they've then lost the entire digit. We spoke about loss of length leading to weakness, and we spoke about hook nail deformity. So all of those things need to be considered in the report. My reports would then tend to focus on degenerative condition reporting. And in this case, the injury didn't involve a joint, and so there's no impact of degenerative conditions. But might they require future surgery? Well, they met with somebody who had already offered them a particular operation to take free tissue from the toe and transplant it up to the thumb in order to gain length, or to take some bone graft from the hip in order to try and lengthen the bone that's been left there at the moment. So that type of operation needs to be discussed, and it needs to be costed in terms of the potential for future surgery. So normally I would give an indication of the percentage chances of needing to undergo each treatment in the future, and a likely indication of what the costs might be. In terms of chances of undergoing future treatment in the hand and wrist, if you're instructing hand and wrist experts, it may be worth bearing in mind that that is fairly nuanced, and that often we will offer surgery to people who have undergone injury in the past, whether or not they want to go through the trauma of the operation, the subsequent rehabilitation, and the loss of earnings is fairly nuanced, and it's a decision that they will make obviously very personally. So they may be offered further surgery, they may well not want to take up that further surgery. So in my reports, there will always be a clause that suggests that, you know, they would be entitled to meet with a surgeon to discuss these particular treatments, and that the chances of undergoing them do not mean that the chances of a hand surgeon offering them that treatment are the same. They're often very different. In almost all of these cases, there will be a significant psychological injury. And so if you're instructing a hand and wrist expert for this kind of injury, you may want to send them for a psychological opinion at the same time. And if they've suffered an amputation, almost always there'll be a role for a prosthetist, so somebody who makes prosthetics, and prosthetics can come in two types. They might be aesthetic, so that people have a more normal appearance, which can help them with the psychological injury, or they may be functional. So they may just extend the length of the digits such that somebody can meaningfully pinch, and that can be very helpful in terms of activities of daily living. Let's think about a second case now. So this is an injury to the hand. And we previously suggested that in general terms, injuries to the hand may be better tolerated than injuries to the finger. This is unfortunately an exception to that rule. This is a joint dislocation at the carpometacarpal joint. And this is a left-handed software engineer who suffered a fracture of their dominant thumb metacarpal, which then led to instability of the carpometacarpal joint. So maybe if I can demonstrate that a bit more clearly on the x-rays, this block of bone down here is supposed to sit up on the trapezium. And as a result of the fracture, that the whole thumb has been allowed to slide. And you can imagine then anytime you try to pinch, they would experience pain around this area, and their pinch will be significantly limited. So they had, on this occasion, met with a surgeon who talked them through the damage to the joint surface, which they felt was really quite significant. And they didn't think that surgically they would be able to piece the different bits of bone back together. So under those circumstances, an external fixator was recommended. So this is a device almost akin to Meccano that you might have become acquainted with in your childhood, which is used simply to pull the joint into distraction, with the intention that the supporting ligaments around the joint will then tighten and the bits of bone hopefully come back into a more uniform position. So this is not a perfect means of reconstructing a joint. It's a fairly rough and ready way of doing it, but in the context of this injury, it was felt probably to be the best option. They spent 3 months off work and then underwent a phased return over the period of 3 months. At the time that they met me, a year or so after the injury, the grip strength was still markedly reduced because of ongoing pain and instability at that joint. And you can imagine that if you suffered an injury and you were placed into one of these devices for several weeks, that would have a significant psychological impact as well. So in the context of a report, in this case, diagnosis and causation were very clear. The prognosis is more uncertain. So this was an intra-articular fracture, so a fracture within a joint, and those are at significant risk of arthritis. This is an injury, and it was comminuted. So comminuted just means multifragmentary. So this is likely to lead to significant ongoing pain and stiffness. At the time of my meeting the claimant, they were unable still to do heavy household tasks, and they were unable to cycle, which was their primary leisure activity. So the prognosis is uncertain, but certainly I thought there was a risk of needing future hand therapy to be between 50 and 75%. Future intra-articular injections, that would be usually of steroid, although sometimes other injections are preferred, to be 40 to 60%, and the chance of future surgery to be 40 to 60%. So in terms of degenerative condition reporting, it is clear that this person is going to develop secondary osteoarthritis. They can't not develop it as a result of that injury. And the costs of the likely future treatment then are provided as part of the report. If we move further proximally again, so now we're into the wrist, and we've suggested that there's really quite a wide spectrum of wrist injuries, and some will be relatively benign and some will be really quite significant. The case we're going to talk about is a 35-year-old right-handed human resources worker who was hit by a motorcycle, who was a motorcyclist hit by a car at about 30 miles an hour. And they had a combined injury with a fracture of the distal radius, so the radius being the longer bone on the outside of the forearm, but also an injury into the ligament that sits between the scaphoid and the lunate. And those injuries to that ligament are notoriously difficult to manage and notoriously lead to significant sequelae in terms of future risk of arthritis. As part of the same injury, they had sustained a fracture to the 5th metacarpal neck. So in everyday practice, often these are termed boxer's fractures, where there's been a direct blow to the finger and then a fracture sustained across the metacarpal neck. And those of you who do box or have boxed in the past will know that really that's a misnomer, because if somebody's punching or striking appropriately, the impact should be to the index and middle metacarpophalangeal joint, and really they shouldn't put much impact at all through the little finger. So if you're a purist, then you would say that the term boxer's fracture is inappropriate, but we digress, so I'll put myself back on track. They sustained some grazing and abrasions, and obviously a significant psychological injury, partly related to the loss of function and the loss of hobbies. So in this context, this person had undergone an operation to put a plate on the front of the radius bone to realign it, and they'd had a reconstruction of the scapholunate ligament at the same time. When I looked through the x-rays after meeting the claimant, the x-rays looked excellent. They looked really, really good. I thought that the reconstructive job that the surgeon had done in this case to put the different blocks of bone on the distal radius back together, they had done a fantastic job of that. And they had got the scaphoid and lunate alignment looking perfect. But actually, despite that, the severity of the injury was such that the claimant still had significant ongoing pain and stiffness. And in terms of degenerative condition reporting, well, these are injuries that carry a really quite significant risk of osteoarthritis in the future. So I've suggested 60 to 80% within 20 years. Future risk of hand therapy, so physiotherapy for the hand, 50 to 75%. Future steroid injections, 25 to 50%. And the risk of future surgery, 1 to 10%. But there will be a clause in that report that suggests that although the risk of future surgery is just 1 to 10%, that doesn't necessarily mean that future surgery wouldn't be offered. And in my clinical practice, often people come to see me following a scapholunate ligament injury, and that sets off a particular pattern of arthritis. And I will offer them a whole remit of non-operative treatment. And if that were to fail, I'll offer them a whole remit of operative options as well, including an operation to take away pain nerves to the back of the wrist, or a partial wrist fusion or a total wrist fusion, or an operation to take away any remaining joint cartilage and put a plate and screws on the back of the wrist such that it doesn't move again. And if it doesn't move, it can't cause pain. But of course, that comes with quite a significant functional limitation. So it's not that future surgery is not indicated. It's just that not many people want to go down that path, and people may end up as a point of personal preference living with pain rather than sacrificing the movement, which would be the only salvage option that we have for their pattern of arthritis. And so that is drawn up into a report that will cover all of those different areas, along with the cost of future treatment. So we'll move away from injuries to the bones and talk now about injuries to the soft tissues. This is a description of a gentleman working on roofs who fell from height at work, and he was taken to hospital by ambulance because of concerns about other injuries. Later on that admission, it was discovered that he had difficulty moving his fingers, and he was off work then for 5 months afterwards, had significant ongoing mild difficulties with activities of daily living and with work. But of course, this is somebody who's a manual labourer who, by definition of their work, works outside all year round. And that's important when it comes to future recommendations. So this person had a laceration to the deep tendon of their finger, and a partial thickness laceration to an adjacent finger. There was still, at the time that I saw them, very significant stiffness, which would be expected following such an injury. So in order to approach and then operate on the front surface of the finger, you can imagine if the laceration was here on the ring finger, you have to mobilize a lot of the pulley system in which the flexor tendons run in. So there are 8 pulleys running down the length of the finger which stop the tendon from pinging forward when you initiate flexion. And if you were to approach the finger for surgical repair, then you have to violate some of them. Some of them you will keep preserved because of their significant importance on future function. But following that surgery, the finger will swell, and it's very difficult then for the claimant to get that finger moving again. So there's always, with these injuries, really quite significant stiffness. And actually, what is deemed to be a good surgical result, which would usually be a slightly stiff finger, which still allows activities of daily living, maybe with a mild degree of pain, is of course not what a claimant might think of as a good surgical result, which would be put me back in the position that I would have been in but for the accident. And unfortunately, in many cases, that's not achievable surgically. So in this case, I thought that further significant improvement would be unlikely, having seen them at 12 months, and that there really wasn't much of a role for further surgery, which would carry significant risk. So the options there would be to lengthen the tendon, But if you lengthen it, then there's a risk that they can't achieve full flexion because of the various different tension points that the flexor tendons have to have. So there is, in theory, with these cases, a small risk of the tendon repair snapping later than 12 months. That risk is really tiny in the literature. And there is a risk of requiring a later operation to try and free up scar tissue from around the tendon. That operation is called tenolysis, but later than 12 months becomes very unlikely. And the need for further hand therapy, well, at the time of meeting them, I thought that the two tendons were a little bit stuck together, and so the recommendation therefore would usually be further hand therapy at a cost of £600 to £800. But importantly, in view of the fact that they work outside, they're likely for the rest of their life to need thermal gloves at a cost of £200 to £300 with a lifespan of 2 years. If they were to need further surgery, then that would be costed as well. So tendon injuries are difficult to manage, and the outcomes for claimants, unfortunately, may not be what they were hoping for when they first embarked on the surgical treatment. Here's a last case. So this is a description of somebody who sustained an injury to their nerve. This is somebody who works with glass as a glazier, sustained a laceration to the right wrist, and suffered a division of the radial artery, the superficial radial nerve, and one of the tendons that brings the thumb out to the side and allows you to get span, all of which were repaired. If you sustain a fracture to a bone and a surgeon uses a plate and screws to put that bone back together, then the bone will heal. And depending on the techniques they've used, there may in the future be no evidence that a fracture had ever taken place. The same is not true of injuries to nerves. The function after a nerve repair is never normal, and there will usually be a patch of dysesthesia, so altered sensation related to the distribution of that nerve. And there will often be problems with neuroma, which we spoke about during our introductory slides. And if somebody suffers a neuroma, then the pain and suffering from that can be really quite significant. And that will often lead to the need for future surgery to excise the neuroma. Anytime you cut a nerve, however, the nerve will try and regrow again at a different level. And so you can end up in a scenario where people are chasing neuromas further and further up the forearm. And that leads to techniques where you might drill a hole into the bone and try and put the nerve into the bone such that the end of it doesn't come into contact with any kind of tapping in the local environment. So outcomes following nerve injury are not what you might hope for, and certainly not what you might expect following fracture surgery. We said that pain and sensory disturbance are common. If the injury has involved a motor nerve, then weakness will be common, and there is often a role for future surgery, which may be just taking away scar tissue from around the side of the nerve to try and encourage the nerve to function again, or maybe neuroma surgery, or in complex cases, maybe taking nerves from elsewhere in the body that are more expendable and then putting them into a gap to try then and get a nerve to fire in order to reconfigure nerve function in terms of motor function. So how might you approach all of this if somebody comes in to see you for help with their personal injury case? Well, early settlement is probably not advised. It's often difficult to know quite what the natural history of that particular injury pattern is going to be until it declares itself, and that will often be 12 to 24 months down the line. So if you're instructing experts for hand and wrist injury, you may want to wait a little bit longer before you book them in to see that expert. As I said, there will often be a psychological impact, and it's been my experience that often when people come to see us for hand and wrist reporting, they haven't had any kind of psychological assessment or intervention. And usually people involved in a road traffic accident almost always will have some kind of psychological impact from that, and frequently In my experience, that involves driving potentially several miles to avoid a patch of road where their accident happened, especially if it happened along their daily commute. And if people are knocked off their bike, then almost always, in my experience, they won't be back to cycling at the level that they were cycling at previously, not because they're limited necessarily by their injury, but they feel anxious about it, or they haven't been able to get into the headspace where they feel comfortable on a bike again. So I think that is probably under-recognized in our industry. And if you're sending somebody for a hand and wrist opinion, you may want to think about that at the same time. Hopefully, our reports can help you position the claimant within a JCG bracket, and that will move them up and down brackets in terms of what the likely settlement is going to be. Hopefully, our reports can help you determine minor, moderate, or functionally significant impairments, whether or not the defect is permanent, and what areas of their life are affected. So, what would my final messages be? Well, they would be that hospital discharge doesn't necessarily mean normal function. So just because somebody went home from the emergency department after an initial X-ray doesn't necessarily mean that they had no impact of that injury, or in fact that the diagnosis is no significant injury. It may be that they do have one and it's just simply not been picked up. Similarly, following their treatment, they may have been discharged from hospital care, but it doesn't mean that they've been restored to normal. Many of them will have lasting cold intolerance, and for those who are working outdoors or spend a significant time outdoors for their hobby profile, it would seem reasonable that they should be afforded protective gloves in order to carry on their hobbies or employment. And in my experience, almost all will have a significant psychological injury, and there will be varying ways that they might have vocalized that. And in my experience, often they won't have done until somebody specifically asked them about it. So I suppose my final message is that probably the value of the claim is not determined by what's broken, but rather what the residual functional deficit is, so what no longer works. And I think that's broadly what I wanted to talk about. So there are probably a few minutes for questions, Leo.
Well, first of all, thank you very much, Rupert. That was incredibly insightful, and I particularly enjoyed the different case examples that you brought. Just to remind you all, the Q&A function is above, so please pop your questions in now if you have anything to ask. Before we jump to that, I just want to make all of our viewers aware of our next webinar, which is coming up on Thursday, the 14th of May. And we are moving across to birth injury with shoulder dystocia. And we have the lovely Nikki Khan, senior midwife, who is extremely experienced, who will be focusing on this area and practical tips, tricks, and things to look out for in relation to this quite well common and often seen injury in birth injury claims. However, I was back to today into the Q&A. Rupert, I was just commenting on your final slide about the JCG valuations. Do you find that they fully reflect the functional impact, or is there a gap between the valuation brackets that they set out and what you see clinically?
Yeah, so that's an interesting point, and there are, of course, factors that move somebody up and down a JCG bracket. Probably the one that in clinical practice we might take slight exception to is hand dominance, and we didn't really talk about that actually during the talk, but the JCG brackets will put a lot of emphasis on hand dominance. I think probably it's my role to add a clause in the reports of non-dominant hand injured claimants that just because it's not their dominant hand doesn't mean that the functional deficit isn't significant. You can imagine that if you're right-handed and you lost function from your left hand, that is really still very significant. So I think in clinical practice, although we talk about hand dominance, we probably put less impetus on it and we associate less importance with it. And it would seem unfair that a claimant who has injured their non-dominant hand should be prejudiced just because it's not the hand they write with, if you know what I mean. So I think that it's our role to really focus on all of the functional loss and make that very clear, even if it's not a dominant hand.
And is there anything solicitors should do when instructing you or when assessing cases to focus on this point to ensure that the valuation for any particular injury is fully considered?
Yeah, well, I think probably it comes down to dialogue. So the hope is whenever we're writing reports as expert witnesses that they meet the expectations of the solicitor. Of course, most people write very thorough instructions, and that's very helpful to us. I think if you were returned a report that you felt hadn't addressed a particular point, then certainly within my practice, my intention is that our expectations should align. So I would welcome any further correspondence, and we can work out where the areas of attention are greater required. So I think in terms of positioning within different brackets, I think if it's not clear from a report, then all of us writing expert witness reports would welcome further correspondence so that we can help that person with the appropriate positioning in terms of the bracket.
Fabulous, thank you. So we do have a couple of questions which have come through. First of all, Deborah King and Andrew Tyndall have both asked whether you comment on clinical negligence matters. And if I'm correct in saying, at this point in time, you focus exclusively on the personal injury front. That's correct, isn't it?
Yeah, so my focus has been on personal injury reporting because but the standard that I had set for writing negligence reports was probably 4 years in practice as a consultant, just that is the standard at which you can become then an examiner for the FRCS. So I think if you're commenting on people's practice, I am now 4 years in, and so I will be starting a negligence practice, yes.
Wonderful. So to answer your question, Deborah and Andrew, send your inquiries straight through to us and we'll obviously direct them to Rupert. Carol Simpson has asked a question. Where there is a nerve injury, is it necessary to instruct a peripheral nerve surgeon as opposed to an orthopaedic hand and wrist surgeon? Are they both considered the same, or are there different scenarios where one is preferred above the other?
Yeah, I think that probably depends slightly on the nuance of the case and on the proximity of the injury level. So, for example, in hand and wrist surgery, we see a lot of nerve injury as part of our practice, and we operate on nerves to repair them. So, for example, they're probably commonest at the level of digital nerves in the fingers, where we would be repairing lots of digital nerves in the context of laceration. And so any hand and wrist expert would be happy to comment on that. The same would be true of an injury to the median nerve at the wrist. But by the time you're getting above the elbow, then that fits more in the remit of a peripheral nerve injury surgeon. And at that level, the implications on residual function are different because the nerve following a repair would be expected after a delay of about a month to regrow at around 1 millimeter a day. So if your nerve injury is at the level of the elbow and it's going to advance in terms of function, probably the length of your thumb every month, you're looking at different amounts of time to get final end organ function back. And you have about 18 months following a nerve injury repair for motor function to come back before the motor end plate, so the bit of the where the nerve joins the muscle in terms of helping the muscle to fire, that will die back after about 18 months. So at that point, or if you felt that there wasn't progression, then if it's above the elbow, that would usually fall under the remit of a peripheral nerve injury surgeon to then counsel the patient about whether they want to undergo a nerve graft to try and speed that up, or in fact tendon transfer surgery. So tendon transfer surgery would fall under our remit, but more proximal nerve injuries and certainly anything around the brachial plexus are better dealt with by a peripheral nerve injury surgeon.
Thank you. Thank you very much. There doesn't seem to be any further questions in the chat at the moment, so perhaps I can finish off with just one thing slightly off topic. Obviously, orthopedic surgery is a large area with many different specialisms. perhaps you could share very briefly, is there a specific reason why you developed a practice within the hand and wrist area of orthopedics rather than the other bodily parts?
Yes, so I suppose every orthopedic subspecialist will advocate for their own area and tell you why their area is more interesting. For us in the hand and wrist, you know, that area has very beautiful anatomy. We tend to be able to make people better with our operations, and that can be, you know, on a personal level, very rewarding. And we've had really very significant advances. So, for example, one of the cases that we talked about was somebody who'd had an injury around the carpometacarpal joint, and in the past we had really very rough and ready treatments for injuries around that joint. We've now got a fantastic new joint replacement. And for ligament injuries around the wrist, keyhole surgery, so arthroscopy is really developing. So there is a very exciting field to be involved in. Certainly I feel that things are really moving forward in hand and wrist surgery in terms of the techniques we can offer. And then, you know, there are lots of different joints, all of which are very complex. And so that comes with a degree of thinking, whereas, you know, your hip colleagues, they may employ less thought during their average consultation, but I'm sure they would tell you something.
Well, thank you very much. And I think I summarize on behalf of all of us to say that was a fantastic hour well spent, really interesting, really intuitive, and I'm sure has taught all of us here a lot. So all there is to do is, Mr. Rupert Wharton, thank you for your time today, and thank you everyone for attending. I wish you the best rest of today and the week ahead, and look forward to seeing you at our next webinar.